of the session of Dr. Raskin, and I am also the chair of the AI task force. And about 5 years ago, we had the idea that SAGES should be a leader in artificial intelligence for surgery. We created this task force, and among the task force due diligence to implement this new technology was to establish the foundations for a sustainable and scalable surgical AI, which they included standardizations for surgical video annotation. We're going to be talking about annotation today. Standardizations for the video structure. We're going to be talking about that as well. Discussion of governance and also implementation of research projects, such as the critical view of safety challenged. They're going to be also presented today. For this long session, it's 3 hours, we got a fascinating faculty group, and the way it's going to be structured, on the first part of this section, we're going to have more basic science and more explanation about what is annotation, what is computer vision, natural language processing, applications, current applications for surgery, for training. Then we move forward and go more in-depth discussions, including ethics, governance, and also the critical view of safety challenged. After the first group, we're going to have a panel discussion here, and I welcome each one of you to come to the mic and ask questions or submit the questions electronically. You'll be monitoring them here. Then we're going to have a little break, and then after that break, we're going to have the second part, followed by another Q&A panel. So this is a very interesting topic that many other societies are getting engaged right now, and I think it's super valuable as a surgeon to understand the basic concepts of AI, and then to be pairing with engineers to take this to your home institutions and really furthering this, then just allowing us to be hearing from industry saying that's how it should be implemented in your OR. Talking about industry as well, we have a very good collaboration with them for the last 3 summits that we put together under the Innovation Weekend. We have a close collaboration with the engineers from the industry and with the engineers from academia. So there is a lot of planning where we are coming from, 3 years ago to today, and I really hope this is going to keep going bigger and bigger, and then you guys are going to be getting engaged, and there is getting engaged through joining the AI task force, or is getting engaged by email. One of the presenters is going to come and talk in here. And also encourage you to be pairing with engineers to really move this forward. So with that being said, I would like to introduce the very first speaker, Dr. Jackson. It's right there. And she's going to be giving us the introduction about the basic concepts of it.
Thank you so much. How great is it to be back here at SAGES in person? This is really fantastic, and thank you so much for putting together this session and the opportunity to speak. Today, what I'm going to do is give you a very quick overview of artificial intelligence, or AI. I'm going to talk about what AI is, discuss some basic concepts, and why AI is gaining traction in healthcare today. I'll also touch on what types of research or scientific evidence are needed to allow AI to be adopted safely and effectively in healthcare settings. So before I get started, I'll address my conflicts of interest. I am now an executive at Intuitive Surgical in a scientific strategy role, and my compensation involves salary, stock, and stock options. I was earlier this year a chief science officer and chief health officer at IBM Watson Health, and so I still own stock in IBM and Kyndryl. And I practice surgery part-time at Vanderbilt University Medical Center, where I'm paid to do surgery. So I'm not planning to discuss any of the products or services of the companies that I have worked for in the last year, or the services that I provide at Vanderbilt, but if I do, I will try to support what I say with scientific evidence. So let's start with, what is AI? Well, artificial intelligence, very simply, is a term that is used to describe intelligence that is demonstrated by machines or computer programs that mimic human intelligence. I will only touch today on the computer science techniques that are used to create modern AI systems, but for the scope of this talk, but the key functionalities that characterize advanced AI systems are the ability to understand, to reason, to interact, sometimes in human-like ways using conversational technologies and voice or text, and the ability to learn, programs that can learn and improve their performance over time. Now, most contemporary artificial intelligence programs use a computational technique called machine learning, which involves algorithms or programs that can perform a task without explicit instructions from a programmer. So old-fashioned or early computer science programs followed exactly the code that was written by a programmer, but machine learning algorithms build mathematical and statistical models, and they build those models based on patterns that they find in the data that they process. And then they use those models to do things like classify things, such as identifying structures in surgical videos or radiographic images, or to make predictions, like predicting one's risk for a complication after surgery. And although it sounds quite complicated, you can think about machine learning in a very simple way. The computer is taking inputs, like the data from a digital image of a skin mole, and then generating an output, such as a category, benign or malignant, or a probability, such as the likelihood that a lesion is malignant. And there are two main types of learning, supervised and unsupervised. In supervised learning, an algorithm learns from a training set, or a set of data that is annotated in input and output pairs. For example, you could take images or videos from cholecystectomy and label some as having an adequate critical view of safety and some as not. And then the algorithm would learn a function that could map from that input to the output. In unsupervised learning, the algorithm actually discovers categories from the data, from the input data. And the most common form of unsupervised learning is something called clustering, which will identify groups of the input examples that share some commonalities. And my favorite example from this is actually an analysis that was done on patterns of patient portal messages, so patient-provider messaging, and it identified patterns such as appointment preppers and lab checkers and hover moms. So you may have heard the term deep learning. And deep learning is a subset of machine learning techniques in which the mapping of input to output occurs in multiple steps or multiple layers. And with each layer, progressively, higher level features or abstractions are generated from the raw data to progressively identify the ultimate output. And deep learning methods are often called neural networks, as they were inspired by the complex network of neurons that you see in biological systems. Now, a really common misconception is that AI is a new or emerging technology, and it's absolutely not. So artificial intelligence was established as an academic discipline in computer science in the 1950s. And when I started my career in biomedical informatics, which was about 30 years ago, I wanted to do AI research, but I'm a pragmatic surgeon type, and I really felt like the world wasn't ready for AI to have an impact. And now there's a ton of hype around AI. And so what's different? Well, in the early 1990s, there wasn't much healthcare data that was available online. People didn't use EHRs or computerized systems, and when they did, they had really small siloed data sets. And since then, as we all know, there have been advances in the technologies to store data and increased adoption of electronic health records, PACS systems, and a whole bunch of other health information technologies. So we actually have the opposite problems. There's growing and complex data set, and 80% of data in healthcare is completely unstructured. So again, early in the days of AI, data sets were stored separately, often using different hardware and software, and they didn't talk to each other. And now we have technologies that can share data and process it securely, like hybrid cloud and blockchain. And finally, over the last decades, we've seen both advances in hardware and computational techniques like deep learning and quantum computing that actually give us that computational power and the tools that we need to analyze and utilize complex data sets. So now really is that time for AI to take off in healthcare. It is also the case that artificial intelligence technologies already exist and are already used by all of the stakeholders in the healthcare ecosystem. So there are tools like for healthcare providers like ourselves that provide clinical decision support. They can do things like predict one's risk of suicide in an emergency department encounter. There are tools for healthcare payers that can detect fraud in claims databases. Tools for people who purchase healthcare, like those little chatbots you might have used to select your health benefits plan during open enrollment. There are tools for policymakers that can predict the effectiveness of a particular initiative, like wearing masks. And there are tools for life sciences companies that can help accelerate targets for drug development or to optimize clinical trial design. And there are even tools for patients that can take in their data and diet and activity and help them manage their chronic diseases. So With all that, many of you are probably still a little bit skeptical of such tools. And a big question is if they're being introduced into your practice, or your patients are coming and say, I have this great little app that I'm using to manage my disease, you might ask, do they work? And that's actually a really good question, because when things like drugs and devices are introduced into practice, there are sometimes multiple studies that are reviewed and approved by the FDA, whereas for a lot of AI, especially that developed at academic medical centers where they're in marketing claims, or those that are used to assist clinicians rather than replace them, they are not regulated. So I think it is really important for those of us who develop AI systems to do the scientific studies that show that they're safe and effective. So I'm going to spend a few minutes talking about what that science should look like. This slide shows a very simple framework for the evaluation of any health information technology, including AI tools. And you really need to do, very simply, three things. You need to show that the tools technically work, that they can be used by their intended users in a healthcare setting, and that they have an impact. So that first step is showing that the algorithms technically perform well, predicting risk or classifying things accurately. And although that sounds really scary, the evaluation of a natural language processing or a machine learning algorithm is very similar to the evaluation of a diagnostic test. And you measure the performance in things like sensitivity, specificity, area under the curve. When we know tools technically do what they're supposed to do, you need to put them in the hands of a real clinical user and make sure they can use them to accomplish the tasks they're intended to accomplish in a real healthcare workflow. And finally, we ultimately want to show that AI tools have an impact, such as saving lives, reducing costs, reducing recurrence. When AI tools are first introduced, you often are going to look at those proximal or process incomes, such as do clinical decision support tools change decisions? And it is only with time that you can look at the longer-term outcomes, such as a survival, a recurrence, or reduction of cost. Now, evaluation should be done systematically to avoid confounders. This is basic science. So when AI tools are first introduced, it's us clinicians who are the ones that are often saying, you know, I'm really not going to believe this until I see a randomized controlled trial that shows that it reduces recurrence. And while randomized controlled trials are certainly a long-term evaluation goal, if you do not know that your tool works technically and you have not evaluated its usability in a real clinical workflow, you are setting yourself up to fail. And I will also say, and many of you have probably had experience with this, when you introduce a new technology, you have no idea what that effect size is going to be. So you need to do those preliminary studies to understand that. Repetition is also really important whenever something changes in the way that you're using an AI tool. So a natural language processing tool that works really well in a primary care setting may not work when you throw it at the notes that are written by trauma surgeons or rheumatologists. And this process needs to be repeated whenever conditions change, especially if you have algorithms that are learning and changing their performance over time. Now, this sequential approach really isn't different than what you know about research for drugs and medical devices, although there are a couple of important differences. So you can think about that preclinical phase as your algorithm development and prototyping your tool. And here you're doing sort of proof of concept technical performance. In your phase 1, testing for safety and efficacy, you want to evaluate your algorithm on a very robust data set, something that's reflective of what it will be used in, and do usability testing on your prototypes. In phase 2, you want to put your tools in real clinical workflows to see what the users do with them and evaluate for performance, usability, and then integration into that workflow setting. And here you can estimate your effect size, which will lead you to your phase 3 definitive randomized control trial to evaluate impact. AI tools, like anything else, need monitoring for performance, which can change based on a large number of factors, changes in the underlying data, changes in your target population, or an algorithm learning over time. So I hope this framework gives you an idea of the types of science that you should be looking for at meetings like this when you're seeing evaluations of AI solutions. So since scientific strategy for AI tools has been my job for almost 4 years, I'm going to give you a few tips. First, real clinicians should be involved in AI evaluations in healthcare to set thresholds for performance. So if you are evaluating an AI tool that automatically interprets a radiographic image, the consequences for missing something like a lung lesion are really high. So that false negative is really important, and you need a clinician to tell you that this is a really, this is a tool where we really need to avoid those false negatives or false positives, depending on the context. Now, when you think about how AI tools should perform, knowing and establishing that baseline performance that you're trying to improve is super important. So in the 70s and 80s, when people were developing the first diagnostic AI systems, knowledge-based systems or expert systems for medicine, people would arbitrarily choose a threshold. And they'd say, like, yeah, if we're doing diagnosis, it should be about 90, 95% accurate. And when they actually went back and looked at what the doctors were doing in practice, they weren't that accurate or they weren't that consistent. And so you need to know that baseline of which you are trying to improve, to have reasonable expectations about what your performance should be. Now, if your AI tool is intended to be used by a human being, you need to expect the unexpected. So AI algorithms differ significantly from drugs and devices, which tend to function in a relatively predictable manner. But if you are giving the output of your AI system to a human being, they need to understand it, they need to trust it, they need to contextualize it, and then they need to be motivated to take an action on that output. And so, whereas, again, drugs and devices perform in a relatively predictable manner, humans do not. And there are a lot of steps between the output and the action. And I would say look for challenges in interpreting the results of an AI algorithm, mistrust, or creative new uses for the information, or even unintended consequences. Finally, when you get to, when you get to that comparative trial, it's also important to choose the right comparator. So if you are evaluating an AI tool that is intended to be used to assist a clinician rather than to replace that clinician, although people love the drama of human versus machine, I worked at IBM, we're partially responsible for that, for the Jeopardy thing, your appropriate comparison is the human with and without the tool. And finally, and I think most importantly, don't skip steps. So plan your evaluation systematically to include technical performance, usability, workflow, and then impact. Many of the failures that you have seen of AI systems in clinical settings are those who have skipped steps in their development and their evaluation. So this talk has been a very quick tour through some of the basic concepts of AI, some of the reasons AI is gaining traction in healthcare, and hopefully for this scientific meeting, an overview of the types of scientific evidence that you should be looking for in AI systems. I'm really grateful for the opportunity to speak, and I'll be happy to take any questions either now or later. Okay, perfect.
Okay, thank you, Dr. Jackson. Our next speaker is Dr. Schiroff. He's a professor of surgery at the University of Toronto, where he practices MIS, foregut, and bariatric surgery. He developed the surgical black box concept, which aims to transform the safety culture in medicine and introduce modern safety management systems in high-risk operating room environments. So please welcome Dr. Schiroff as he discusses AI for assessment of skill, benchmarking, and competency-based education.
Thank you so much. Thank you. And it's wonderful to see that the AI agenda is picking up steam, and so many people are attending this session now in prime time. Let me just see. I'll start with my disclosures. I am also founder of an academic startup that commercializes our black box platform, so I'll avoid any empty marketing claims today. I think we'll hear a lot of those usually throughout the course of the conference. But I think, and I've been using this slide for a long time here, probably more than a year. The time today and the hype around AI reminds me of the time 20 years ago when we were so excited about simulation in healthcare and all the promise simulation brought an opportunity to revolutionize surgical education and change the way we practice surgical education. And I still feel that many of us, despite thousands of publications, feel that the promise of surgical simulation hasn't been completely fulfilled, and I think we want to avoid that. And I think talks like Gretchen's talk before bring some critical thinking and some methodological rigor to the way we introduce these technologies, but also we need to think that research is, or we need to agree that research and thorough validation is important. And this is an image of our research institute downtown Toronto and the symbolic bridge between our research institute and our hospital. And this is something that should remind us always that we need to talk about research, we need to celebrate success, we need to embrace new technologies, new tools, but we always need to think about how do we bridge the research advancements with real clinical care. And if we don't cross this bridge, nothing else matters. I think also something that this is a quote that a good friend of mine and a colleague from Heidelberg, Lina Meyer-Hein, brought to my attention. We've used it in a few grants together. I think it's also important to remember that we're seeing a lot of presentations, a lot of exciting research achievements, but I still feel that in 2022 we have seen very few quality AI algorithms that have crossed this bridge from research to clinical practice, and very few of them will do that. So we need to collaboratively think about not only how we identify new opportunities, how we embrace new technologies and methodologies, but also how we collectively use this final step, the knowledge translation step, and bring these algorithms, these technologies to the bedside and change the way we practice surgery and care for our patients. And if we don't change that, if we don't see an impact on patient care and clinical practice, none of it matters. All this hype is wasted. I think when we talk about AI in surgery, we need to remember the number one statement I want to make today is AI in surgery is not the goal. It's not our goal to develop an AI algorithm. It's just a tool to achieve something that really matters. Can we achieve better patient care? Can we improve educational outcomes? Can we improve decision making? Can we improve clinical outcomes? Can we reduce costs? This is the real goal. And there are many tools, and AI is just one of those tools. It's a hot tool, is a buzzword today, but it's just one of these tools. Also, when we design algorithms, we often define abstract goals. And when we implement an AI algorithm, or try to develop an AI algorithm to achieve these abstract goals, usually it will find a trick to achieve them. And we need to be aware of that. We need to always be critically reflective on the way we design, we validate, and we assess the value of these algorithms. We also need to be very aware that often these algorithms will generate some uninterpretable behavior, and we need to be able to identify that. And I think something that's very critical, and one of my colleagues in Toronto, Professor Rudzik, often talks about the point of explainability. AI algorithms need to be explainable, and it's a whole trend in AI research and that brought to life what we call explainable AI. So what is explainable AI and why is it so important? I think it is important to remember that AI can also bring a lot of biases to life, and we need to, if we want to impact safety, surgical safety, we want to impact patient care, we need to ensure that the algorithms we design are safe, and we need to be able to monitor that. We also need to ensure that they're generalizable, that they're consistent. We need to be able, we need to have tools, and we need to incorporate opportunities to audit their performance. You know, once we develop it, it doesn't mean that they will perform up to standard forever. Once we introduce new device, once we introduce new environment, once we want to apply them in a different healthcare setting, they probably will not perform well, and we need to be aware of that and need to monitor it. It's also very important when we change patient care, when we use these algorithms for real-time decision support or any type of decision support, we need to generate trust in them. And we won't be able to do that if they're not explainable, if they're not transparent and explainable. And also we need to remember that the users have the right to this explanation. If we're changing the way we educate surgeons, if we're changing the way we evaluate surgical performance, especially for high-stakes assessment, we need to be able to explain why an algorithm made a certain prediction. And new, which is not so new anymore, GDPR legislation in Europe adds some very specific requirements to explainability in AI. I'll talk a little bit about the way I feel AI or AI methodologies can dramatically impact surgical education. And it's been now more than 20 years since OSATs came to life. Many of you who have experience with objective structured assessment of technical skill developed by Professor Raskin and colleagues in Toronto. It's still used widely around the world for assessment, both for formative and sometimes for summative assessment. And this is it is a global rating scale that has identified 7 parameters, and an evaluator, usually a human evaluator, ranks a surgeon's performance on a scale from 1 to 5. And a very typical thing we see these days is when you don't bother to watch the entire video, we just give average to everything, and this straight lining is a problem that we've tried to deal for a very long time. So we need to remember, why do I mention that? Is if we try to create a data set where we evaluate a video and we assess technical performance using a global rating scale, and then we generate a large data set and we develop an algorithm. Obviously, this type of data is not going to be very useful to develop a valid algorithm for assessment of technical skills. So we need to be aware how we develop these assessment tools. And also we need to remember that performance assessment and meaningful performance analysis is way more complex than what we've done in the past, looking at kinematics or global rating scales. For example, there is a huge interperson variability as well in our performance, depending on many other factors. So we all know, we've all experienced days in the operating room where we feel that nobody could do this procedure better than us, and we're at the top of the world, and there are some days where the same surgeon performs extremely poorly. And that's all. There are a ton of hidden dependencies there. Was the surgeon on call last night? Who was the assistant? Who is the nurse? Who is the anesthesiologist? What kind of technology we use in the OR today? What are the level of distraction? So in order to address complex issues and really make an impact on surgical education, on surgical safety, we really need to understand how complex this is, and we shouldn't be looking for shortcuts. So high quality data is critical, and holistic analysis of the data sources is critical. I'll provide a couple of examples of some areas where we've made some dramatic impact or the dramatic progress in the way we evaluate technical performance of surgeons. And this is one of them. We've been working on something for more than 5 years now, looking at the next generation of OSATs, the replacement of OSATs with something that's explainable, something that's subjective, something that's meaningful, and something that's actionable. So something that we can use to provide higher quality coaching and higher quality assessment. And we need to remember that this needs to happen not only in laparoscopic surgery, but something that's even more complex in open surgery, where we really need a platform that captures data and provides analytics that are meaningful to the surgeon. So this is a prototype that we've been using for analysis of performance in open surgery. It's an AI-driven camera that identifies the hands of the surgeon and quantifies motion, identifies a bunch of other things like instruments and intraoperative adverse events. So this next generation of analysis tool, we call it our vision. We've gone through a systematic approach of how we design it, not only based on motion data, but also based on data that is clinically relevant. So when we, for example, conduct a procedure and conduct a dissection, not only how we moved our hands, what kind of instruments we used, but also did we cause any adverse events? Was there anything that could impact patient safety that's important to take into account? And this way we can generate a score that's valid and objective, but also this score can be an intervention on its own, because if a surgeon sees this score and it's explainable, they can then modify their behavior. We've done a lot of work validating these algorithms, and we feel that that will start making impact on the way we train the next generation of surgeons. So again, this type of AI algorithm is a specific example of how we can use this to quantify performance and provide near real-time feedback and provide benchmarking, so we can compare surgeons, we can compare, and we can use that for both formative assessment to provide feedback, but also summative, where we can use it for some of the critical steps in the development of the surgeon, for selection, inter-training promotion, and also certification and recertification. And this is the part which is very, very important, where explainability comes to be in focus. Here, the resident not only should be able to see a score, or a practicing surgeon not only should be able to see how well and what is the score of their performance, but also why the AI system provided a certain score and what components of the procedure it took into account when estimating the score. And this is, we see performance. We've traditionally looked at performance as a static value. For a 3, 4, 5-hour procedure, we were accepting a score on a range between 1 and 35. And we all know that there are segments of the procedure where the performance would be outstanding, and some segments where the performance would be suboptimal. And we should be able to see that, and we should be able to understand and see the video corresponding to this assessment segments. So, and why does it matter? Why does technical assessment of technical performance matters? There are a ton of studies there showing association between technical performance of the operating surgeon and clinical outcomes. It started with the Berkmeyer paper a few years ago from Michigan. We've replicated it in a number of surgical specialties like advanced upper GI surgery, urology, gynecology. So we know that technical performance matters. But here we can see the true variability of technical performance of a cohort of residents and practicing surgeons. So if the scale is from 0 to 100, we can see that there is a massive variability, and we've intuitively known that for a very long time. Variability is a challenge in surgery, and we need to do everything we can to shrink it, because it does matter. So here is an example that for every 10-point increase in the technical skill score, that corresponds to 10% decrease of the incidence of high severity intraoperative adverse events. So performance matters. We should be able to measure it. We should be able to learn from it. We should be able to use it for quality improvement and for better education. And this is important. Measurement is important, and AI can make a significant role in that process, but it's not enough. We need to remember that just measuring it doesn't mean that we'll be able to improve it. So it all starts with the measurement, though. If we can measure our performance, if we in terms of technical performance, in terms of non-technical performance, in terms of communication in the operating room, we can identify a baseline, we can understand what needs to be improved and how, and then we can use that information to actually deliver educational intervention, whether it's through coaching, whether it's through simulation, through deliberate practice, or other methodologies that are available today and we know are very well validated in other high-risk industries. So in this way, we can close this circle of improvement, where everything starts with measurement, and then with the next step, which is introducing deliberate practice interventions, and then measuring again how these interventions, or coaching, or how these interventions actually changed clinical performance in real life. So this is where simulation, clinical practice, and modern technologies can play a synergistic role that will result in better care and better education. And this is an example how we've done it through a number of coaching interventions where we can use technology, where we can use AI to dramatically increase the efficiency of the coaching process. Because we all know that we can introduce requirements for hours of video review post-operatively and providing coaching. That way, we need to really identify areas that or segments of the procedure where this a review or a coaching intervention could be of value, and areas which could benefit from improvement. This is something that we analyzed or assessed through a randomized trial a couple of years ago, and we showed that through this approach, we could dramatically, significantly increase performance, and we could reduce the errors in adverse events with 50%. So to summarize, we need to very soon start asking ourselves the question, how do we make this next step of knowledge translation? We are already seeing a number of research papers out there that show validity and of high-performing AI algorithms. And there is no doubt that it can play a very significant role in this processing of high volumes of unstructured data and turn it into meaningful information that can help us improve. We also need to remember that we shouldn't be blindly trusting these algorithms. We need to critically evaluate them. We need to be aware of their advantages and disadvantages. We need to move to the next step of performance assessment beyond global rating scales and simple kinematics. We need to always be aware of the requirement for explainability. That will make us continuously improve these algorithms, but it will also increase the trust of our users and in general the surgical profession in AI. We need to continuously audit the performance of these algorithms, and if we continue doing that, if we introduce these frameworks for thorough validation and critical reflection, I think we can achieve the promise of simulation and AI and help us revolutionize competency-based education and scale coaching. So I'll stop here. Thank you again for inviting me, and looking forward to the discussion later.
Thanks so much, Dr. Grantcharov. Amazing talk. We will take questions later. Now we're going to invite Professor Guy Rosman. He's like one of the few engineers in the panel coming up to talk about what I think is one of the most important areas of artificial intelligence and computer science in surgery, which is computer vision. Dr. Rosman graduated from MIT. He has a man with many hats. He works on an autonomous vehicle project from Toyota Research Institute, and also he's our Associate Director from Engineer for the Surgical Artificial Intelligence Innovation Laboratory at Mass General in Boston. Welcome, Guy.
Thank you, Oz. Thank you for having me. I'll start pretty quickly. In terms of disclosures, so none of what I'm going to show here directly relates to my funding sources, which are research-wise in clinical studies, Olympus Corporation, and on my other hat at the Toyota Research Institute on autonomous driving. So in terms of what is computer vision. So computer vision is a subfield of AI that allows us to have computers describe the world that we see in one or more images and to reconstruct properties of that world. In our case, we're strongly interested in video, in a sequence of images, and that field relates to other fields in AI, such as computer graphics, where you actually generate images, robotics, where you take the properties you inferred and make decisions and move machines, and machine learning and AI in general. In terms of recent high-impact results that we've seen, obviously self-driving cars have made a lot of headlines. We take sensor inputs from cameras and LiDAR and whatnot, and we can actually decide how should we move the car, how to interact with other road agents. We've seen a lot in medicine in general, different imaging modalities, and different applications and tasks in medicine. And finally, there's a lot of impact through sort of more day-to-day computer vision tasks in terms of recognizing faces and in terms of being able to make sequential decision-making, such as even the results on Atari games or beating humans at Go. All of these are basically heavily influenced by computer vision. Of course, we've seen the whole discussion of deep fakes and how does that affect whether or not we trust what we see in the media and so forth. These are a few applications. What I'm going to talk about is mostly about tasks. Basically, what is the kind of thing that we wanted the machine to do in this case with the image? And this is important to notice when you look at computer vision results, because this is something that you can later take and translate to the clinical problems that you're interested in. So I'll go briefly over computer vision tasks. When people hear computer vision, they often think about image classification, image in, and categorical answer out, such as, is this an inpatient image? Is there a bipolar grasper in this image? Usually people often think on the day-to-day examples, such as, is there a dog, is there a cat, and so forth. So on the right, you can see a few of these examples, and on the left, you can actually see an example neural network that basically started the sort of the latest wave of deep learning results by saying we can actually just use a deep learning network and get pretty good result on a broad ImageNet kind of classification benchmark. And the fact that it's so commoditized, the fact that you can just take a neural network and labels and go and train, that's what's giving it a big impact on other fields as well. Next kind of thing that you can do with computer vision is to infer geometry. So questions such as, what is the 3D location of things? Where is the camera with respect to the scene or the patient? The distances of objects, their sizes, and so forth. These are things that we often want to measure and use for higher level reasoning in surgery. Next we have, and related, is detection and tracking. So object detection is the part where we look at an image and we want to detect the location and is there such an object in the image? Where is there a bipolar grasper in this image? Tracking takes it notch further and basically locates a specific object throughout the video, which allows you to start reasoning about trajectories and motions and things that lead to, like people mentioned, performance analysis and so forth. More recent and more sort of related to the deep learning revolution is our ability to do semantic and instance segmentation. Semantic segmentation is the task of looking at an image and for every point or pixel in the image, ask which semantic class it belongs to. So it can be, is this pixel related to a person or is this pixel part of a liver tissue? Instance segmentation is a slightly refined version of that, where you actually care about individual objects. So not just this is a tool, but specifically this is one tool and the other region is another tool, or similarly lesions in an image and so forth. And these use a mixture of appearance and shape cues to understand what are things in the image. And this is important to note because when you're looking at an image, you want to ask yourself, okay, how can I do this task and does the computer have enough information to do that? These were all very much localized around a few frames, but our end goal is to be able to understand the whole surgery, and that requires temporal analysis. So traditionally in computer vision, people have done activity recognition, action recognition, and so forth. This also exists a lot in surgery, and people have looked at task recognition, action recognition, surgical phases, workflow analysis, and basically try to understand from, as the computer sees the frames over time from the video, different factors that you can tell about the surgery as it's occurring, such as phases, such as actions and tasks, and so forth. But we can take this to a larger context and ask, what's the bigger picture? Eventually, when a surgeon looks at a video, they have their own web of knowledge, their own knowledge graph, and they're trying to understand for all of the different things that they know about surgery, what's the state of these in the surgery that they're currently seeing. That relates to the point that Dieter mentioned about explainability. We want algorithms that can actually understand all of these different things and grow these algorithms when we have more data and we can annotate more examples and we care about more and more complex scenarios. So can we build an extensible AI framework that slowly grows in terms of the breadth of what it's capturing? And we've done some initial work in that direction in a recent archive in basically inferring a whole knowledge graph about a surgery as we see the surgery and slowly growing that graph as we have more data. This was all about past information, this was analysis, but we can also do prediction. People have done a lot of prediction tasks in computer vision, so you look at images or other signals and you want to forecast what's the future going to look like. They've done that in terms of video frame predictions, trajectory predictions of human behavior. In this case, it becomes very important to reason about uncertainty because inherently human behavior is uncertain and you don't have all of the context. It's important to keep note of that. Finally, you want to start asking what is the exact structure of human behavior and which phenomena am I trying to mimic? And that goes back to the question of what's the downstream impact and what is the downstream task that we're trying to achieve with this kind of algorithm. So, and that also relates to some recent work that we're presenting in this ICRA, where we're really taking a general workflow labels sort of definition, and instead of analyzing, we're actually predicting over the next 15 seconds what are the possible next phases, when is the transition going to happen. And this is, again, is a pretty extensible framework where you can have additional patient factors and you can still do the rollouts and predict what's going on. So these are all different machine learning tasks, but it's also important to understand what is the context and what do I expect computer vision to do when it comes to minimally invasive surgeries. And there are a few differences from standard computer vision. First of all, there's a lot of deformable geometry and specular surfaces because of soft tissues and bodily fluids. But the other thing is that we have a very specific field of view. That field of view is partial. It requires us to reason about the whole surgery and have a state and understand what already transpired. But on the other hand, this is what the surgeon sees when they take actions. So the information, in a sense, is there. And finally, another difference is, of course, the taxonomies, and Dr. Eckhoff is going to talk about it later. But basically, in surgery, we have our own set of labels and different semantic entities, and it's important to reason about what can we label and what do we need to label in order to get good results from a computer vision algorithm. I'm going to mention briefly that, yes, we did not focus here about beyond the laparoscopic view. There's obviously a lot to say about the OR, like Dr. Grancherov has mentioned. And in that sense, these are closer to natural or in the wild day-to-day computer vision. But obviously, there are many challenges there. Finally, just to mention in terms of getting into this field, there are two key differences in terms of the literature. One is, so this is a list of relevant computer vision, robotics, and ML venues that are all relevant. And some of them will have either medical examples or algorithms that are relevant for medical. Another thing to notice is conferences and even archive papers play a much heavier role in computer vision. Basically, by the time a new neural network algorithm gets to CVPR, a computer vision conference, it already has been for a few months as an archive in many cases and may have acquired quite a bit of citations. Doesn't mean that it's peer-reviewed. CVPR, however, all of these conferences are peer-reviewed, and a lot of the algorithms are basically published there and not necessarily even in the journals. Finally, you want to ask yourself, what do I need to ask about computer vision literature? And this has been discussed in the previous slides. We want to ask, what is the premise? What is the context? Is it rigorously tested? What aspects of the testing that was done there would actually apply to the clinical problems I'm interested in? And what was the original premise in the approach that they took, and why does it make sense for me? Finally, when we look at how to interact with computer vision, you want to be minded of what's possible, and this is why I focused on the tasks. As you're looking at different scenarios and clinical problems, data sets are priceless. I cannot stress this enough. It relates both to achieving results, to coming up with new problems to tackle, and also starting to get a better sense of whether this algorithm will work when it's actually deployed, like Dr. Grancherov mentioned. And finally, you want to reason about which taxonomies are of interest, and think about what is the right level of uncertainty in these taxonomies. And of course, there are many computer vision scientists that are looking for new problems to solve, and they'll be happy to engage and collaborate. I'm gonna, in my slides there are also the references. I'll be happy to take any questions, and thank you.
Thank you. Thank you, Dr. Rossman. I want to encourage everybody to submit questions from the floor, as we're going to have a panel discussion after our next speaker. And I have the privilege of introducing Dr. Daniel Hashimoto, who's currently a fellow in minimally invasive surgery at the Cleveland Clinic, yet a very accomplished surgical data scientist. As a general surgery resident at MGH, he co-founded with Dr. Meireles the SAIL laboratory. And he's also the editor of a textbook that was recently published, Artificial Intelligence in Surgery, Understanding the Role of AI in Surgical Practice. So join us in welcoming Dr. Hashimoto as he talks on current and future implications of AI in surgical training.
Thank you very much, Dr. Raskin. So I'm at University Hospitals, which in Cleveland, it's very dangerous to try to confuse the two, but thank you. So these are my disclosures. So I do some consulting for J&J and Verily, and some advising for Active. I will not be speaking at all about anything related to these industry affiliations. I am on the board of directors of a nonprofit, the Global Surgical AI Collaborative, and I was previously research supported by Olympus, the Intuitive Foundation, and the Crico Risk Management Foundation, although the research support is currently not active. All right, I think that's my 7 seconds. All right, so when we think about where we are in surgery today, it's helpful to think about where we've come from. You know, you think about historically how surgery started out. It was very much a relationship between the clinician, even historically the barber, right, and that patient. And maybe there were some instruments, scalpels or more primitive knives. Maybe there were some herbs and spices to function as a sort of rudimentary anesthesia. But by and large, it was fairly crude. And today, we're now living in, I think, what I would call an era of device-enabled surgery. So we do have much more sophisticated ways of practicing our craft. We have some devices that have stood the test of time, the scalpel, scissors, certain graspers and things, a schnitt or a tonsil, depending on what part of the country you're in. And we have things that are more advanced, staplers, electrosurgical devices, robots, right? We have image-guided surgery that has become a thing with MRIs and CT scans, fluoroscopy, ultrasounds, etc. Ultrasounds are now plugging into our phones these days even. You know, I don't know that I would have even thought about that, you know, when I started medical school. But all of that has really led to the digitization of the operating room, and that has given us access to data. And so we're now beginning this transition from an era of device-enabled surgery to what is really sort of the oncoming future. It's data-enabled surgery, right? And that's allowing us to better understand, okay, well, how do we start to incorporate data that we've gathered from populations, from samples of a population, to make better decisions about the patient that's in front of us? How can we better understand that patient-specific data and how it fits in the context of the population so that we can make the right decisions as clinicians? And that also impacts how we think about training. How do we use the data that we have about our trainees? You think about the complex information that Dr. Grantaroff presented. How can we use that to better improve the education and training that we are providing? And it's not just to medical students and residents, it's to our own colleagues. You know, there's a lot of momentum on peer coaching. In fact, I think there's a coaching academy on Saturday that SAGES is hosting. And so this is something that is relevant to each and every one of us who are practicing. And when we think about how we like to do performance evaluation, we think about some of the things that we have available to us. Dr. Grantaroff talked about OSATs. So pick your favorite 5-letter acronym. There seems to be some rule about Likert scales that they got to be a 5-letter acronym: GEARS, goals, OSATs, etc. And that's one way that you can certainly do some evaluation, but you have other things available to you as well, right? When you think about when you get credentialed, what do you have to do? You have to submit a case log. When you think about certifications that we all have to get, ACLS or ATLS or what have you, to demonstrate some base level of knowledge. And then we think about other things. Well, how can we use video? How can we use our outcomes? And more importantly, how do you integrate all of that data in a way that allows us to come up with meaningful performance evaluation, whether it's formative or whether it's summative? And now what we're doing is we're entering this era where we're trying to use different techniques. We're trying to use computer vision to analyze that video. We're trying to use natural language processing to analyze the way we write notes to better determine, you know, where are our deficiencies as clinicians? Where do we fall on a scale of performance? Are we novices? Are we experienced? Are we somewhere in between? And more importantly, what are our areas of weaknesses that we can address to continue improving ourselves so that we can deliver better and better care to our patients? And that has, I think, really sparked an interest in thinking about how we can use this video and other types of data in novel ways. And I think SAGES has really been a leader in that. When you think about what SAGES has done with video-based assessment and really thinking about how to do this in a systematic and scientific way so that you can provide rigorous review from video. And that has now, of course, spilled over into the American Board of Surgery, which last year launched a pilot on doing video-based assessment in surgery. And some of you may have participated in that pilot. And the reason why we can start thinking about how we're going to use some of this data now is because A, we have better access to it, and B, we have technologies that can make the process of reviewing these types of data just a little bit easier. It's not perfect yet, but it removes a little bit of the burden of having to sit there for, you know, a 2-hour, 3-hour, 4-hour, 5 operation and watching the whole thing. Or more dangerously, skimming through it and thinking we've watched the whole thing and potentially coming up with incorrect assumptions about performance. And so when you think about some of the technologies that are available, this is work that Dr. Mascagni is going to potentially talk about, or at least he worked on last year, which is using AI algorithms to try to just identify relevant clips in an operation. So in this work that he presented, published in Annals, they were able to use algorithms to try to identify the relevant 2-minute video clip in a lap chole where the CVS was most likely to be achieved or being attempted to be achieved. And on top of that, if you look on the right-hand image, it's actually the use of different networks that have been built to try to help surgeons understand, did they achieve the critical view of safety? Did they identify the 3 criteria that are put forward by the Safe Chole Task Force? Did they identify 2 and only 2 structures? Is everything cleared in the hepatocystic triangle? Do you have enough of the cystic plate exposed? And so you can now start to use these algorithms to provide feedback automatically. So instead of having to engage another surgeon's time to sit down with you and review your performance, some of it can be automated. And then you can engage with that surgeon for more qualitative elements in terms of how you manage your performance and how you can get improvements. Dr. Amin Madani has previously published on his work on the Think Like a Surgeon platform. It's a web-based sort of software platform that allows you to upload video. It can then prompt you to ask a specific question. So in this case, if you were a surgeon, where would you begin your dissection given this video clip and this frame of that video clip? You can then compare your results to that of experienced surgeons, who have engaged in this and who may be senior hepatobiliary surgeons or just senior surgeons in general who are interested in cholecystectomy. And this has nothing to do with AI to begin with, right? This is purely human annotation, and it's a mechanism to give feedback to others in an automated way, to say, listen, we can disconnect you from that coaching process, at least initially, so that you can engage with this video at your own pace, and you can compare your performance to that of others. And that allows you to see, okay, well, I actually fell quite a bit away here from where more experienced surgeons may have wanted to start their dissection. So maybe I need to rethink my frame of mind, my frame of reference for how I think about what's a safe and unsafe place to start. And so that has sort of immediate educational implications. But downstream, you can then take these types of annotations effectively and feed those to an algorithm. So you can feed them to an algorithm that can take this type of information and try to automatically identify safe and unsafe areas of dissections, what we've called go and no-go zones, to effectively build like a GPS for surgery that can try to define for you, based on prior expert annotation, what is most likely to be a safe plane of dissection that you can engage in. Where should you stay away in the red to try to prevent injury to the common bile duct or to the duodenum? And in fact, most recently, actually just 2 or 3 months ago in Toronto, Alan O'Kranick and Amin Madani were actually able to run this live in an operating room on a patient to see how it might impact their decision-making as they were engaging in this type of work. And so it'll be really interesting, I think, to see how does this perform. And we've been doing some research on how this performs actually on videos of common bile duct injury to see does it appropriately identify the no-go zone and could it potentially have prevented that bile duct injury. We're still working on that analysis, but preliminarily I think it's some very exciting results to come, I think. Thomas Ward, who was at MGH at SAIL, also did some work that he presented at SAGES in August and is now published in Surgical Endoscopy. It's using deep learning algorithms to try to identify certain types of aspects that come from the video. So I think somewhat analogous to the things that Dr. Grantaroff presented, he's done work to automatically try to classify a cholecystectomy based on the Parkland grading scale to understand what is the impact of inflammation on the overall trajectory of this case. And what he's found that for every 1 point increase in the Parkland scale that was automatically identified, there's an 8-minute increase in operative time. But moreover, there's an increased likelihood of injuring the gallbladder, potentially making a hole in the gallbladder and spilling bile and stones. It did not, however, impact the likelihood of attaining the critical view of safety. But what I think was a more interesting result from this study that he did is the thought that surgeons are impacted differently by what's happening in the operation. So on the left panel, what you see is the average impact of Parkland grading scale on a group of surgeons' likelihood of spilling bile and creating a hole in the gallbladder as part of their dissection. Overall, there's very little effect on the Parkland grading scale. But when you look at the most affected surgeon, who's in the right panel, you can actually see there was a pretty interesting contribution that as the Parkland grading scale went up, as there was more inflammation, this particular surgeon was more and more likely to have a gallbladder injury and spill bile and potentially stones. And I think that highlights that we really have to be willing to do the work with these types of novel metrics to better understand what is the distribution of these events and how do they impact not just the group, because if you just took the groups data, you'd say, okay, not a big deal, there's not that much of an effect. But really do the deep dive into your data and try to understand, okay, I have some novel metrics and novel data sources available to me with this new technology. How can I better understand individual performance against that of the group? And how can I better understand how I can target my educational interventions to try to bring up everybody's performance and really try to bring up the performance of the whole group by targeting specific individuals? A lot of work that's been done in other fields, like urology, I think also has interesting implications for education. Andrew Hung at the University of Southern California is a urologist who's done a lot of work on automated performance metrics in robotic surgery in particular. So he's able to obtain the kinematic data from robotic platforms and better understand that for each step of an operation, how do these metrics influence the patient outcome? And it's not just the things that we're used to counting, like bleeding and typical complications, but it's patient-reported outcome measures. What is the likelihood that this patient's going to have incontinence or sexual dysfunction? And what he's found is that these automated performance metrics do have some ability to predict whether a patient is going to have potential issues with their outcome. And they can specifically target that to specific tasks of the operation. And they've been using this to better understand, okay, how do the highest performers differ from the lower performers? And then how can we get them to work together to try to improve that performance so that everybody improves together and uses these novel metrics to understand their performance in new and meaningful ways? This has also been applied in neurosurgery. And instead of a robotic automated performance metrics, these are computer vision-based metrics for endoscopic neurosurgery. Dan Donahoe at Children's National in DC has done this work where he has looked at a simulation. So this isn't actually real neurosurgery. These are sort of silicon models, where he's able to look at APMs to track instrument usage, movement, task-specific interactions to try to understand when are they obtaining hemostasis and when are they not. And what they found is that they can use these APMs and it correlates with blood loss, and they can specifically target these surgeons and say, hey, listen, if we modify your decision-making or your motions based off of this kinematic data that we're obtaining from computer vision, you might get faster control of your blood loss, and you might have lower overall blood loss and improve your performance and outcomes. I think also it's interesting to think about how this AI work is impacting some things that we're used to historically, like VR simulation. Stephanie Speidel, who's in Germany, has done a lot of interesting work using generative adversarial networks to create more and more realistic VR simulations. So she can start with something like in panel A, which is a very rudimentary sort of computer graphic, and by using AI, different types of AI models, can actually feed in real images to make that image more and more realistic so that by the time you get to your final VR simulation, it has a lot more realism and higher fidelity. There's also, of course, this is applicable in open surgery, has been demonstrated by a few of the previous speakers. And many of you have probably seen similar graphs like you see on the right here. There's always comparisons of, oh, this is how an attending performs, this is how a medical student performs, this is how a resident performs. But the real hard work that we have to do now is, so what? So what does it mean if an attending is different than a medical student? Of course they should be. Now let's better understand how we're going to use these metrics to bring up those medical students, those residents, those other faculty members to try to get better and better performance and try to get the best possible training that we can get to deliver better care. And ultimately what that means is that there's going to be some component of virtual coaching or automated coaching and in-person directed feedback like we're getting. And we really have to try to find where is that line, what is okay to deliver in an automated fashion, and what really needs that human component so that we can really lead to those improvements. And a lot of the community on the engineering side of things is very interested in working on this. CliniCai is a component of MiCai, which is one of the big computer vision medicine conferences that's happening in Singapore this September. And CliniCai specifically for clinicians. And there's a call for abstracts that's open now. And so I'd certainly encourage you to really think about translational work that you may be doing with others in this field and to also engage in other types of challenges. Dr. Mascagni is going to present the CVS challenge at the end of this meeting as well. Ultimately, what we know is that this is becoming a new fundamental competency. The Royal College of Physicians and Surgeons in Canada presented this report just last year, and what they're realizing is that this is going to be a fundamental part of our practice going forward. It's going to be a key component of our education, and we really need to think about how do we integrate teams of clinicians and engineers together. And we really need to do that by collaborating. This is the Metrics Reloaded project for Nature Methods that's really trying to figure out how do we identify the right metrics to evaluate performance of AI models for specific clinical tasks, and how can we disseminate that to help people make better decisions around understanding and then publishing their work or interpreting that work for use in their own practice. And then, of course, education and training, scientific meetings like here, dedicated fellowships like they have at SAIL, and just thinking about incorporating this into curricula and having other access to other resources, like there's some lectures at WebSurge and through CAMA. And yeah, that's basically it. We really need to think about now, let's do the hard work and really take all this exciting technology and think about how we're going to use it to better ourselves and to better our institutions and our processes. Thank you.
Thank you, Dr. Hashimoto. Thanks for the great talk. I'm going to invite all the prior speakers to serve as panelists right now. That's going to be about 20 minutes of questions. And then we're going to follow that with a break. We had to change the schedule a little bit because one of the speakers could not make it. So I encourage you guys to keep sending questions here as well. Also, feel free to go to the mics for questions. All right, so I'm going to start broad questions to the panel here, and I see that each one of you have kind of chose different paths in your careers, and they all met with surgical AI, right? And then some of them probably were intentional, others weren't, right? So I will start with Guy first. How do you see surgical AI actually playing a role in a society? Because we know how the planes can fly, you know, the self-driving cars, you know, like a Siri and everything else. I hope they didn't activate any phone. But my question for you is, like, do you see in a foreseeable future that we're going to start seeing applications of surgical artificial intelligence in our clinical practices?
Well, I agree with what's been said by both Dr. Ganshov and by Gretchen, that basically it's a long road in order to actually get a fully deployed, safe, stable, product-level surgical AI. I agree with Dr. Hashimoto that we need to start that road and get there. But basically, I think the key is to find the niches where AI can make a difference today and the specific applications where this can already happen.
That's great. So, Dr. Jackson, what do you think? I mean, you've been in so many industries before. Do you see, like, in the near future, you're going to be able to utilize this, or still a bunch of, like, only minimal viable products and a bunch of research?
Yeah, I think Dr. Hashimoto made a really good point that where we are is trying to figure out what are the best applications for AI. And I think there are certainly things that machines do a lot better than human beings. So, and these tend to be things that are tedious tasks, like counting cells in a pathology slide, or measuring things. And those are the types of things that we can use AI applications to completely automate, because computers can likely do them well, and they can likely do them more accurately than humans. And then for the other things that require things like clinical judgment or compassion, or even, we haven't gotten to the point of automating common sense, that those are the things where you use the best kind of AI, which is augmented intelligence. And that's combining what humans do well with what machines can do well.
That's great. Dr. Granshov, comments on that?
Yeah, I completely agree with that. I think that there is no doubt that today computers can help us in many ways to convert these large amounts of unstructured data, for example, surgical video, into some meaningful information. Although at the same time, I think it's important for us to continuously remind ourselves about what the real question is. What is the real goal? AI is not the goal. The goal is the goal. And the goal is, can we turn this information into real impact on efficiency? Can we reduce costs? Can we improve performance? Can we reduce variability? Can we reduce intraoperative adverse events? So can we improve educational outcomes? So I think we need to remind ourselves what the real question is, and how a tool like AI, together with other tools, can help us achieve these goals. AI has a lot of advantages. It can allow us to scale things. It can allow us to do things in an objective way. It can allow us to reduce costs, for example, annotation or video analysis. So I think I have no doubt that we'll see some significant advancements, but as we do that, we need to do that in a thoughtful way and constantly remind ourselves why. What is the value, and how do we continuously audit and improve the performance of these systems?
That's great. And then Dr. Hashimoto, can you comment on this as well, but more focusing on the education, the surgical education level?
Yeah, absolutely. I think, to Dr. Grantraw's point, I think one of the things that opens up possibilities is the idea that AI is not the goal, it's the tool. And I had attending a medical school who used to tell me, whenever I would blame an instrument, Dan, it's not the tool, it's the tool behind the tool that's having the problems. And I think about that both from an education perspective and just from a general AI applications problem, is that if you're thinking about building AI for the sake of AI, what you're going to do is you're going to train AIs to try to think like we do, which is fine because it's an easy way to wrap your head around a problem, but why? Like, do you want a computer to think like you do, or do you want it to think differently and better than you do? As Dr. Jackson said, there are things that computers can do better and more efficiently than we can, so why do we want it to replicate our inefficient cognitive processes? And so if you focus more on the goal, now you can rewind that question a little bit and say, okay, I'm trying to achieve a goal. Well, what's your goal? Your goal is not critical view of safety. Your goal is avoid bile duct injury. And critical view of safety is a good human concept for avoiding that. But is that the best machine concept? Does the machine have access to data that we cannot understand and that we cannot interpret? And so therefore, there are different ways that a machine can avoid a bile duct injury that may be more efficacious. Those are the types of questions that we have to be willing to ask ourselves to really try to, I think, get to the full potential of what these technologies can offer.
Yeah, and I would say also, on top of that, AI is one tool, and not all automation requires artificial intelligence or deep learning. So there are automation tasks that can greatly improve what we do in surgery that do not require an AI solution.
We have a question. Dr. Peretta?
Yes, hi. Dan, everybody, spectacular presentation, but I have a question for Dan. How do you translate the way we teach and educate today and the way we assess our students, which is mainly based on numbers and on quality, so quantity versus quality, into something that is meaningful? Because the idea, you provided a solution, but what kind of data are we feeding? How we do that transition, and maybe it's a bigger question also for SAGES in general.
Thanks very much, Dr. Prada. I think that's interesting because the question that really comes down to is all of the things on which we're assessing individuals, and particularly trainees, are surrogate measures of performance, because what ultimately matters is the outcome that we get, whether it's at the end of the training cycle or at some point in their career. And I think what I would hope that we can begin to do as we get better at building out registries and tracking things longitudinally, we now have these sort of like all-encompassing EHRs that are just taking over the world, that we would hope that would allow us to better track what happens to patients. And then can we figure out a way, using new techniques, whether it's AI or not, to better understand the individual contribution of a surgeon, of a internist, whatever you have, toward an outcome. And that's an interesting research question in and of itself. And I think that's obviously the holy grail from an education standpoint, is to figure out what is the individual contribution to outcome. And I think the baby steps to get there are better understanding some of the novel data streams that we have, and then trying to feed that back in an actionable way so that we do improve the surrogate markers like we've been doing, but then really try and do that work of trying to tie those surrogate markers to the outcomes to better understand, are we measuring the things that we want to that we need to measure to get good performance evaluation?
I have a question that kind of dovetails off of the education piece. So there's been complaints about the 80-hour work week, that our surgery residents are not getting the training that they need in the 5-year allocated program. Do you think with these technical skills scores, these video-based assessments, high-level performance assessments using AI, that we will lengthen the training process, or will we potentially shorten it?
Yes. Both ways. I think, the question I think comes down to how does this relate to competency-based education? And a lot of the work that was done in Toronto by Richard Resnick back in the day, and they demonstrated some success in shortening the training cycle for orthopedic residents, but also lengthened the training cycle for others. And I think this is now going to force us to really think about, we have been for a very long time in a time-based training system. And as we get better and better data, it will not be ethical to continue to remain in a time-based training system, because there are going to be people who are better or faster, I guess, at moving through training, and they shouldn't have to give up time, months, years of their potentially productive life to continue to stay in an arbitrary system. Vice versa, somebody who is going to progress a little bit more slowly, we have an obligation to our patients to say they're going to have to stick around a little bit longer to meet the competency that we need to make sure they're going to be safe.
And I think AI can play a dramatic role here. I really feel that it could be a tool that will help us achieve this vision of the transition from variable outcome, fixed time, to fixed outcome, variable time. And I think in order to do that, we need valid, objective methods. AI could be one of those.
I think there are great opportunities here, not only for that initial training process, but for that continuing professional development. So as someone who may want to pick up a new technique or use a new technology as part of their practice, if we can objectively measure what performance and competency looks like, then we can follow them through the learning curve, not only during residency, but actually after practice, when a lot of times you feel stalled or you stop learning in your mid-career. I also think there are some competencies that people who are clinicians will need to learn to use AI in their practice. And that's something that I have been working with a group at Vanderbilt University Medical Center in the education department to define what those competencies are.
Yeah, I know. It's even interesting enough, like Guy Rosman, right? He's just started working for Harvard Medical School to start introducing curriculum for medical students. It will be optional, of course, in the beginning, but to be enabling them to get involved with AI. And just before we get the mic, one question coming from the computer there. That's a very important question to the group. Is like, how can one start getting involved with AI? It's a very good question, and I will start off Dr. Grancherov.
I mean, like any other research field, I think nobody can solve this alone. It's a massive field. It's a massive opportunity. We should be collaborating to conduct studies. And actually, in AI, it's even more important to collaborate, just because a single center data will not be sufficient to answer some of these questions or develop reliable algorithms. So I think how you get involved, probably as a first step, participate in initiatives at some centers, and there are a number of those in North America, in Europe. Many of them are represented here, who already have built programs where there is need for collaboration. But also, I think as we increase visibility and through sessions like that, I think there will be more centers who start their own independent initiatives. But I still feel that we and society like SAGES can play a significant role in that field as well. And the AI task force is probably a great forum to engage individuals in collaborative projects.
Exactly. It's only when we really get to know the field that you can also have ideas and hypotheses to move forward, right? And one thing that's going to come up also from the CVS challenge, and I couldn't be more excited for that talk to come anyway, is that as the challenge progresses, it's going to be not just 1 year, it's going to be several interactions of the challenge. There's going to be this community being built around surgical AI for clinical meaningful goals. And you're going to be able to start pairing, like maybe you have a lot of data and a lot of ideas, but you don't have engineer power, and vice versa. And you start pairing, across. So this community that's being presented here today, like we all know each other, we all collaborating, we all been working together. There was somebody on the mic.
Amir Sold from Tel Aviv. I think I have a question. I think in a way, as clinicians, we're following a linear path that comes from a problem that was defined many years ago. For instance, gallbladder disease, we have to remove the gallbladder. Everything else, we're doing it with technology, is evolving around this concept. So how not to injure the bile duct, how to train a surgeon, how to look at the gallbladder. But I think we're missing around here somebody asking, why should we remove the gallbladder, and can we come up with a solution that's based on technology that will change the concept, not the access? And is there any research defining a problem or thinking about the problem outside the box and looking at technologies that may solve it in a different way?
So there's a group, there's a consortium really sort of between MIT and Harvard that was looking at these types of questions, not for surgery specifically, but just sort of more broadly. When you think about it from primary, secondary, tertiary prevention sort of strategies, you think about sort of when can you, the concept was around disease interception. And so can you use novel techniques, whether they're AI or not, to better understand when patients are at risk to develop symptomatic disease? And then how do you intercept that disease before it gets to a stage where it's symptomatic and there could potentially be downstream negative chronic consequences. Obviously, pharma is very interested in this question, and so you see a lot of this happening, obviously, in the genomic space when you think about treatments for spinal muscular atrophy and what's come up now, when you think about what's happening with CAR T therapy and trying to identify very early on patients who are going to suffer from specific diseases that you want to intervene on. But this is also happening in diabetes research, cardiovascular research. And so these are not foreign concepts necessarily, but maybe they haven't quite been applied to surgery. And I think that's a great sort of point, is we need translational scientists who are willing to really engage in this type of work and think about these problems in a different way than we have traditionally.
I think some of the most exciting work there is actually in the consumer retail space. So if you look at your consumers like your Kroger's, your CVS, who also have pharmacies, who are also large employers, they have data sets about what people purchase and buy. And the CMO of Kroger told me that he can track someone from buying a 12-pack of Coke every week through their diabetic amputation. And that is like the ability for us to use data that we have to understand disease trajectories and intervene is just amazing.
I think that was a fantastic question, Amir. I think we have an opportunity today to make decisions, to ask questions and find answers for so many things that we've in the past relied on traditions, on experience, on anecdotes and so on. I think, and we shouldn't be limiting that to only intraoperative field and execution of a certain technical tasks. We should question everything. When is surgery indicated, how to take care of a patient post-operatively, and make this transition from one size fits all to and achieve the potential of targeted, precise, predictable, ultra-safe environment. And I think data science could be a tremendous tool here to answer all of these questions. I think whether we like it or not, surgery and healthcare will become less and less art and more math. And I think we've got the opportunity today as a profession, to play an active role in this process.
And actually, to build off that, to go back to the earlier question from the computer, you know, how do you get involved and get educated? I mean, there are growing numbers of ways to get educated in surgical data science. I think Professor Pareto may talk about it, but in Strasbourg, they're hosting a summer surgical data science school this summer. Imperial College had one over the winter. It was the Hamlin School, winter school for AI in clinical applications. And I think you're going to see these types of programs growing, and they're certainly welcoming of everybody, whether it's just clinicians or researchers or whoever it may be.
I would also plug my former employer, IBM. IBM University offers education in the data science space for free for anybody who works in an educational institution. So there's no, and they will also give away their AI platforms to use for free. So if you want to experiment, they developed last fall micro-credentials for healthcare providers. So very short courses, very focused courses on AI, data science, and cloud computing. So if you're interested in any of those are things you can go sign up and do on your own time for free. And then they also have a lot of their tools that are available for people at who have a .edu email address. You can go this afternoon, build a conversational agent for 10,000 messages and 1,000 users for free. So there are a lot of tools available, even from some of the industries that provide these things, that you as educators and academics can use for free.
We have 1 minute left on our panel, and this is a question I have regarding what Dr. Rosman said. Data sets are priceless, they're gold, but I'm thinking about it in a different angle. How much data is too much data? And is there a liability to this data? I'm thinking about the black box in the surgical operating room. Is that some way dangerous to the surgeon, maybe helpful to the patient? Thoughts on that?
Well, regarding data sets, then, first of all, there's a big question of which data sets we need, which data is good, which data is useful. But right now, the main problem is getting a large-scale access to data to be able to do real data-driven science rather than hypothesis-driven science alone, which has its own merits. And the other question is, with respect to danger and the surgeon, transition is always a question. But we are trying to first have the tools to understand and then see what's the right joint path forward.
And I think AI can actually play a significant role in reducing the risk for the surgeon as well. So AI and the way we've applied AI in this process is it can help us de-identify data irreversibly. It can help us anonymize data. It can help us achieve this vision where we can take the benefits of data, but also reduce the risk and ensure that the process is confidential, non-punitive, and constructive for us as a profession. And I think, we have an opportunity to play a very active role in this process. There is no doubt that the patients, that our societies, that researchers are hungry for transparency, are hungry for opportunities to improve. If we don't address that from within our organization, somebody else is going to do it for us.
Yeah.
Absolutely, and I just want to add something now about like acquiring data, right? So if I talk acquiring data, you guys can all see the QR barcode on the screens. That's what the CVS challenged. We are also asking people to donate data, right? But then come all those questions and implications. I mean, how much data do you need? What are going to be the governance, surrounding the data? There's going to be any medical legal implications of that, and each institution is going to be very different, and we're going to learn of this process. Just by doing this process, SAGES is going to learn how many institutions at the individual level, state level, national level, going to be dealing with this GDPR, HIPAA, California, even other countries. So it's so important for us to keep pushing the envelope to try to do this, to make this happen, to be comfortable to record your videos, to be comfortable to share your videos, and to be comfortable to get your videos analyzed, or by humans or by machines, because that's the only way we're going to get better. And just to finalize this about how some lawyers perceive that, in my hospital at Mass General in Boston, we're discussing about when should we be keeping videos for the quality improvement for 30 days and then just destroy them because kind of within the protected time. The lawyer said, no, actually, we should keep those videos forever, because more likely a video will going to help to absolve a physician on a trial than actually incriminate. And then if you ever find there was a problem, you can always intervene sooner than later. So it's been a great panel. We're not done yet. We're going to give you guys a break and then come back here in 10 minutes. All right? Thank you very much.